At the bottom of your screen there,
okay, that's
there we go. It's fine now. Continue.
Okay, thank you. Rabies, it's a zoonotic disease which affects all mammals, and transmission is mainly through a bite of one. The disease becomes fatal once clinical signs develop. And the disease is distributed throughout the world, but it has been eliminated from high-income countries. But it remains a challenge in Africa and Asia, where it's endemic, and it's estimated to cause around 59,000 human deaths annually. And of these, 24,000 are reported in Africa. And now there is a global goal of having zero human rabies death by 2030. It's because the tools for rabies control and prevention are known, which is mass dog vaccination, and also provisional post-exposure prophylaxis to people who are always exposed to suspected rabid animals. But to achieve the 2030 goal, the tripartite advocates scaling up mass dog vaccination programs, and these are negligible in most African countries, but also improving access to post-exposure prophylaxis. Now here, the challenge is the cost of post-exposure prophylaxis and the shortages which most of the health facilities have, like the person with the short video which I showed you of a person who lost his child. And as we understand, vaccinating domestic dogs should reduce the incidence of dog rabies, but also reduce the human rabies exposures, reduce human rabies deaths, and also the demand for post-exposure prophylaxis. But the challenge is on the surveillance, which is capable of quantifying the impacts of these different interventions. Now, here in Tanzania, we piloted an integrated bite case management, which is a surveillance tool for rabies that links health workers and veterinarians. The aim was to quantify the bite patients and the demand for post-exposure prophylaxis, but also quantify the human rabies exposures. These are the people who are being bitten by rabid animals or normal health dogs, but also to quantify human rabies deaths and the animal rabies cases. The integrated bite case management has got three main components. The first one is the risk assessment, and this is conducted by the health workers, but also the animal investigations conducted by the veterinarians. And the third component is sharing of results after an investigation has been completed. Now here the structure of the previous surveillance and reporting system which existed in Tanzania or in the study sites or implementing IBCM for introduced it. As you can see, there is no clear linkage between the health workers and the veterinarians. So what we did was to introduce the integrated bite case management system into the already existing surveillance and reporting system under the Ministry of Health and also, but also under the Ministry of Livestock. So we designed an integrated bite case management surveillance app where it contained the questionnaires containing the risk assessment and also the questions which we wanted We trained the health workers on how to do the risk assessment whenever a person came to the hospital to seek treatment. And the health workers, after attending the bite patient, what they do is they fill the electronic IBCM form and upload the data into the central database. Now the database, it creates an automated text message and it's sent direct to the livestock feed worker or the veterinarian, who is from the same area where the animal bite victim has come from. Now, using the information from the health workers, the veterinarians will go out and do an investigation. If we're told they come across the animal which has bitten the person, it has been killed or it has died, they will collect the sample, test using the rapid diagnostic test to confirm if it's rabies positive or not. But also, if the animal is still alive, they will put it under quarantine and observe for 10 days. If it dies, if anything happens, they also have to report the results. Now, the information also, which is collected by the veterinarians during the investigation, is also submitted into the central database, but also they provide feedback to the health workers confirming the status of the biting animal. Now, the health workers' decision on whether the biting victim should proceed receiving post-exposure prophylaxis will depend on the animal investigations. If the animal is found healthy, then the health worker may decide to discontinue providing post-exposure prophylaxis. But if we're told the animal was found to be rabies positive or still suspicious, then the health worker will have to complete providing the treatment to the animal biting patients. But also the information in the database is accessed by the authorities from the Ministry of Health, but also authorities from the Ministry of Livestock. Now, using the information from the health worker, the Ministry of Health will know which facilities have insufficient post-exposure prophylaxis, and then they will make them available so that when patients visit the first facility, they don't miss the human vaccines. But also the Ministry of Livestock will know which areas have high rates of dog rabies cases and know where to invest in mass dog vaccination. So this is the picture of the livestock feed workers doing feed sample correction, and the animal was found to be rabies positive from the rapid diagnostic test which was conducted. The study is implemented across northern and southern Tanzania. As you can see on the map, there are 35 health facilities implementing IBCM, and also there are the health facilities providing post-exposure prophylaxis to the patients in those regions. And when you look at the results, within the 3 years of implementing IBCM, we have seen that the number of animal bite patients who are reporting to the health facilities have increased. In fact, across all the 4 study regions, the number of bite patients reported per month has more than doubled. But also we see that there is a significant difference between the proportion of bite patients being reported with high-risk bites before and after the introduction of IBCM. Similarly, we see that the number of animal investigations have also increased tremendously. If you compare the period before we introduced IBCM, as you can see on this graph, with the shaded color, the pre-IBCM, that's the period before introduced IBCM, and then you compare it to the period after introduction of IBCM, you can see that there are so many investigations which have been conducted by the livestock feed workers, and these are represented by the lines. But also the number of investigations, the number of animal bite patients being reported per month has also increased in each study in each region. You can see that the red bars, that are the bite patients who are being reported, and these are being bitten by suspected rabid animals. Also the gray or the greenish color, these are the bite patients who are being reported due to bites from normal healthy dogs. But also across the 3 years of implementing IBCM, we have been able to document 36 human rabies deaths, but also several animal rabies cases have been confirmed to be rabies positive. But when you look at the world level, through the data collected using this surveillance system, we have been able to identify areas where rabies has been brought under control. For example, in the region of Lindi, there are some districts where rabies has been controlled, and through the surveillance system, it can easily tell, but also we are seeing resurgence in some of the places. Unlike in Mala region where several rabies cases have been reported. But also when you look at the other region like Morogoro, we have been able to detect some outbreaks we have been able to note the areas where outbreaks have been frequently reported, for example, in 2019, 2020, 2021. Similarly, in Mtwara, where rabies has been controlled, you can easily tell from the data being collected and submitted from the different wards. But also in places where we still see some resurgences, we can easily tell from the system, and these are the areas which probably need a lot of interventions to be targeted on. But also we have been able to, the livestock feed workers have conducted a lot of investigations, but the problem comes on the number of samples collected. And here investigations are normally conducted in 2 ways, either through phone consultation or in-person investigations. In-person investigations is normally conducted when an animal has been killed or it necessitates the livestock feed worker to go out into the field and find out more information on the biting animal. But if we can gather evidence of the biting animal through consulting the patient via phone, and then they do that. But here, if you see that out of the 131 animals which were found dead, samples were taken in 43. And this is the challenge which we are now trying to address with the veterinarians to see how we can increase the sample collection to aid further diagnosis. But all in all, we have seen that the number of that rabies cases, that IBCM has improved the detection and the communication between the 2 sectors, but also it has helped to integrate the public and the veterinary sectors and generate more accurate data, which has been used to guide policy decisions at the district level, at the national level, but also we are seeing that the Ministry of Health is using this information to know where they can make sure that they have plenty of post-exposure prophylaxis. However, we have some challenges when we are implementing IBCM. It's because most of the health workers, they don't know much about rabies compared to the veterinarians. And this is because of the training which they received during their professional development. So we have to train them now and then so that they know how to deal with the patients who come with animal bites, but also know how to deal with the human rabies exposures. But also another challenge which we face dealing with health workers the perceived burden of real-time recording. This is because health workers normally have like several tasks, they attend several patients. So at times, if a person comes to the hospital seeking treatment, the health workers may take time to record the information, also send the feedback to notify the livestock feedback so that he does the real-time investigation. And by the time they may receive information, like after 2 days or at times after a week, and when they go through the investigation, they may not be able to find the sample or the biting animal. Or if it had been killed, then it may be rotten and unfit for sample collection. But also on the veterinarians, we have limited resources. For example, the fuel, the motorbikes, and we have the human resource gap. It's also a challenge to aid with the animal investigation, but also the rapid diagnostic testing. Most of these kits are being imported. We are getting them from our counterparts, from our partners in the University of Glasgow. So it's also still a challenge. But all in all, we have seen the benefits of IBCM, and we encourage greater use of it and recommend further implementation and research so that we all realize its benefits as we aim toward the 2030 goal. And another thing to note is that Gavi is currently planning to invest in a provision of human post-exposure prophylaxis. And in order to do that, we need to adapt the use of IBCM so that it can help us to monitor the post-exposure prophylaxis usages. Thank you so much, and this is the end of my presentation.
Thank you very much, Dr. Kennedy, and thank you in particular for keeping to time and for starting us off on that very emotional short video about the human impact of rabies. So I'm just having a quick check. There are a couple of questions in the chat, which I think will be very quick to address, so we'll take those two. So the first person asked, is the diagnosis of rabies based on the rapid test alone, or is there additional test for confirmation? This is Professor Red from Libreville asking.
Okay, first of all, when a person comes to the hospital seeking treatment, we base first on the clinical signs which the animal displays. So the patients normally understand the biting animal. So the health workers will have to interrogate the person depending on the WHO set criteria, which we train the health workers to use. But also after that, if the health worker, then the health worker, depending on the risk assessment which he performs, he will notify the livestock feed worker to go also out into the field. We will also use the clinical signs from the animal, also the information which is provided by the patient or by the dog owner. And then after the animal is found dead, then we will use the rapid diagnostic test to confirm. So we are using both the clinical signs and also confirming using the rapid diagnostic test.
Thank you. One more question, and I think that will be the last one for today. We have Paesa Ragesa from Ethiopian Public Health Institute asks, he says, the One Health approach focus on the prevention than managing the crisis. So hence, from your experience, he asks, what are the major challenges related with the mass dog vaccination in Africa? I know this is slightly sort of a step away from the center of your presentation, but it is a relevant one, and if you can make a comment, that would be welcome.
Okay, thank you. So the challenges related to mass dog vaccinations, we have little commitment. As you can see, the best way or the easiest way to get rid of dog-mediated rabies or to get rid of rabies is through dog vaccination. But which countries in Africa have committed to vaccinating domestic dogs? They are very negligible. They are very negligible. And this is the commitment which we want the politicians, the policymakers to embrace, to take this as like to give it a priority like any other disease. So if rabies becomes recognized and the government decides to commit in vaccinating domestic dogs using its own resources, supplying enough vaccines, and then I think we might be in a good position to eliminate rabies.
Thank you. I have to share that, and I think we also need to increase our investment in the veterinary health workforce alongside the human health one, because they are significantly under-reached our One Health family. I'm afraid we'll have to call it a time on Dr. Kennedy's very, very interesting presentation. If you have more questions, please put it in the Q&A and he will try and address those offline. So thank you very much for that presentation. And we will now move swiftly on to our final presentation for this session. And again, to remind you that there are posters related to this session, which you can access through the program links for this conference. So please have a look at those posters as well. They address both COVID and rabies and their relationship to One Health. So our final presentation for this session is from Dr. Mark Yamba, who is a medical doctor and infectious diseases epidemiologist. He's a researcher and faculty working at the Department of Epidemiology and Biostatistics at the Kinshasa School of Public Health. And Dr. Mark is currently serving as the DRC country manager of AfroHUN, which is Africa One Health University Network, a network of higher education institutions of 10 countries within the mission to train the next generation of One Health professionals. So Dr. Yamba will be talking to us about resistant E. coli in environmental wastewater in Kinshasa. So over to you, Dr. Mark.
Thank you so much, Dr. Iberia, for giving this opportunity. First of all, let us thank all organizers for giving this opportunity to present at this very interesting Congress. So our presentation will be on resistant E. coli in environmental wastewater in Kinshasa, Democratic Republic of Congo. So as we all know, antimicrobial resistance is a public health problem with negative impact on health, economy, and well-being. And that's known from long time. And we also know that antimicrobial resistance is one of the 10 global health issues to track in 2021, according to WHO. So it is estimated that every year, almost 700 million people die worldwide of infectious diseases caused by antimicrobial resistance. But this seems to be very underestimated, as data is not always available and shared on time according to the deaths caused by antimicrobial resistance. It is also estimated that by 2050, almost 10 million deaths will be caused by antimicrobial resistance bacteria, and also it will have an impact on economy with almost $100 billion, with 90% in Africa and Asia. So it is also well established that environmental wastewater plays a key role on antimicrobial resistance transmission. We have also another issue in most of our countries is open defecation and also waste management, which still is a challenge, and it is most of important driver of E. coli shedding in the environment. So in most of our African countries, wastewater is not treated before being released in the nature. We can even directly wastewater from the hospital, from industries is directly in some places released in the environment with high impact in wastewater. But we also know that wastewater is used at the community level for daily activities such as crop irrigation, car washing, and clothes washing, and many other activities where people don't have direct access to safe water. And those people who are exposed, most of them are child or people living with very difficult socioeconomic conditions. When they are exposed to wastewater, they can develop resistant infection, which can also have a very high impact on their livelihoods and economy. As we can see at our left-hand side, this water is used for crop irrigation. As you can see just aside, this is a place where they are using the same wastewater for crop irrigation. And at the right-hand side, you can see people even getting into wastewater without any protection and using this water for car washing and many other activities, which is exposing them to develop resisting infections. So with no data available on documenting antimicrobial resistance status using environmental wastewater, And without any surveillance system to collect information on AMR related to wastewater, we conducted this study with the objective to identify E. coli resistance at the community level using commonly used antibiotics using environmental wastewater. So this was a cross-sectional study conducted from May to June using wastewater collected at 10 sampling points and in Kinshasa, which is the capital city of the Democratic Republic of Congo. To note, Kinshasa has almost 12 million people, and waste management, when you have that huge population, can be very challenging. At every sampling point, 100 ml of wastewater was collected at each sampling point twice a week, twice within 2 weeks of interval. And we also collected our samples at the public abattoir and all the rivers and lagoon in Kinshasa. So all the samples collected were directly conducted, that analysis was conducted at the environmental laboratory at the Kinshasa School of Public Health. And we tested for the susceptibility of E. coli to the commonly used antibiotics. So the used antibiotics that we used for this study, we had amoxicillin, ampicillin, and that you can see, which helped us to see the status of this E. coli identified at the community level in Kinshasa. So according to the results, first of all, in all our samples, all 100%, we isolated E. coli. So in all the samples collected, we isolated E. coli. And we have also seen that up to 69%, we had the pathogenic form of E. coli, which can cause infections at the community level. So the most important result that we wanted to share with all of you is that we found in all the samples collected that almost 80% of E. coli identified from this wastewater coming from the community, from the environmental wastewater, E. coli was resistant to ampicillin and amoxicillin. And as we all know, these are the antibiotics that are very available at the community level, which people can access very quickly, even where pharmacies are not available, they can get it quickly. But as we can note from this study, there is a very high risk of resistance of E. coli resistance to these antibiotics. So to sum up, this study found a very high level of E. coli resistance to commonly used antibiotics, such as amoxicillin and ampicillin. And this calls for urgent measures of wastewater treatment before releasing the community, and also integrated One Health for antimicrobial surveillance in DRC. So we said, let us share some recommendations and see how this can be used to quickly improve antimicrobial resistance surveillance and at the community level. So first of all, we really think that it is good to strengthen antimicrobial stewardship, both in human and animal, improve antimicrobial awareness at the community level, and also improve antimicrobial surveillance using One Health approach. We have seen that most of the antimicrobial resistance surveillance is based at the health facility level, but not taking into account the impact of the environment in the surveillance of antimicrobial resistance. We also note that it is very good to improve water treatment before releasing the community, instead of just taking the water coming from the hospitals and directly or abattoir directly to the environment. And also for those people working with wastewater, I think it will be very important to improve their safety and protection during wastewater reuse. That's what I wanted to share with all of you good people. Thank you very much for your attention. I take this opportunity to thank all those who worked with us in the fields, and also Africa One Health University Network, our network where we build capacity for the next generation of One Health professional. Thank you so much. I'm very open to questions and comments.
Thank you, Dr. Mark. That was a very precise and clear presentation. Much appreciated, I'm sure. We have a number of questions in the chat, in the Q&A, but in recognition of time, I will take the chairperson's privilege to select one or two that I think may be broadly relevant. So there is a question here from an anonymous attendee that says, is there a strategy to access African biosafety readiness, to assess African biosafety readiness in terms of BSL-3 and BSL-4 laboratories for One Health, so both veterinary and human concerns? And is there room for the private sector to come into this space in providing lab space for BSL-3 for pathogens, isolation and research? Now, this is not directly linked to your presentation, Dr. Mark, but in light of your role in the institution that you represent, would you be willing to comment on that? This will be your views, not necessarily the official position.
Yes, I think in my opinion, I think it is very, very important actually to improve biosafety and biosecurity in most of our countries, because when we see our laboratories, we don't have equipment to conduct regularly antimicrobial resistance surveillance at the community level. So it is really very important, and that's what I can say from my opinion, and I leave it also the second part to the Africa CDC, which is really working on strengthening biosafety training and also building capacity across countries to maybe add on top of what we said. Thank you.
Thank you very much. I am sure that the coordinators of this conference will be happy to put some more information in the chat in response to that question. There is, unfortunately, we are really behind on time, and I am sure there will be lots of questions for Dr. Mark. May I suggest that you check the Q&A session, and we will attempt to get answers to those questions that we're not able to address now. So that was the third and final speaker in this session. Again, to remind you that there are posters in the virtual poster presentation that are relevant to this section as well, addressing rabies and COVID and One Health. Please find some time to have a look at those presentations. I'd like to thank all my speakers in this session, Dr. Mark, Dr. Kennedy, and Dr. Marie, and to apologize again for the sound troubles at the beginning. Thanks to three of them for some very cutting edge and interesting presentations as part of our hot topic session. And I'd like to thank the organizers of this very important and very interesting conference, and to thank all 300 plus of you who are still online and listening to these important presentations. And I'll then hand over to my colleague, Dr. Taj, who will be chairing the next session, which will be focusing on partner tools for One Health. So thank you all. Hang on, stay with us. There's another interesting session to follow. Thank you.
All right. No, thank you so much, Ebere. I understand we are a little bit behind schedule, so let me apologize before I start this particular session to let you know that I will be very, very strict with timing. So as Ebere rightly introduced, my name is Raji Tajuddin. I head the Public Health Institute and the Research Division of the Africa Centers for Disease Control and Prevention. And I've been given the big task of chairing this particular session. And this session is looking at what are the different tools out there. And of course, this is to further highlight the operational tools and the different guidance documents that has been developed by our partners to guide our member state as far as operationalizing One Health is concerned. I have 6 different presentations here. And without further ado, I will move straight to the first presentation. And the title of the first presentation is looking at multi-sectoral One Health coordination mechanism operational tool. This is an operational tool that's been developed by our tripartite. That's the WHO Organization for Animal Health and the Food and Animal Organization. And here we have two presenters. We have Stephanie, who is a technical advisor, head of Human-Animal Interface Team at the World Health Organization Emergency Program. And we also have Dr. Kelly, who is a technical officer at the World Health Organization. So it's my honor and privilege to invite Stephanie and Kelly. Over to you, you have the mic.
Thank you very much, Mr. Chairman. Thank you very much for the opportunity and for the interest. This presentation will be made by Kelly and myself, but we could have included a long list of colleagues from FAO or OIE or other organizations who are involved in this work. In fact, since many years, as you know, the three organizations collaborate together to provide guidance and tools to countries to help them to improve their capacity at the animal-human environment interface, including for health security. Kelly, could you please manage? Thank you very much. Maybe you have heard about the process that we follow, who has been developed to help countries to review their performance for core health security capacities, including in the context of the international health regulation, and how we coordinate planning of activity to identify gaps and to fill these gaps using a multi-sectorial One Health approach. Maybe you have heard about these IHR PVS national bridging workshops, during which the human health, the veterinary sector, plus other partners involved have the opportunity to discuss the strengths and the weakness of their coordination for the management of zoonotic disease and to develop a joint roadmap for improvement. During this discussion, in fact, country also requested the tripartite to provide more technical guidance and the option for facilitating the building of this capacity between sectors for a more in-depth implementation of the One Health approach. And this is why in 2018, WHO, OIE, and FAO decided to update the 2010 tripartite guideline on zoonotic disease. With the support of a lot of experts, about 100 of them from all over the world, the new so-called guide to address zoonotic disease in countries was published in 2019 and is now available in all UN languages. Using lessons learned from the recent outbreaks and many case studies from all over the world, the TZG, as we call it, provide standard guidance on addressing zoonotic diseases at various levels of a country. And you will find on this slide the link and a barcode where you can that you can use to immediately access the guide. We also decided to update to develop training material to help to navigate through the guide, and this is something that you can easily access also using your tablet or your phone, and with a barcode. This training highlights some of the most challenging areas for which we have seen that country would welcome some guidance and some support. And in fact, Kelly, if you don't mind, just to explain a little more or describe some of these challenging areas.
Absolutely, Stefan. So once we developed the tripartite zoonosis guide, as Stefan mentioned, there was over hundreds of experts that contributed to the different technical chapters in the guide. And over 80 country examples went into developing this. And one of the major outputs was that countries said these key principles and best practices are wonderful, but how do we actually operationalize that at a country level? And so that brought up the operational tools. So we have 3 operational tools that are currently in development in association with the guide. The first is the Joint Risk Assessment Operational Tool, which is published as of December 2020, and you will hear about that next after this presentation. The second is the MCM, or the multi-sectoral One Health Coordination Mechanism operational tool, which we'll talk about today. And then the third is the surveillance and information sharing tool, which you'll hear about later in the presentations as well. So these operational tools are really step-by-step guidance to allow countries to operationalize those key principles. Now, the One Health mechanism, or sometimes referred to as a One Health platform, is a network of strategic partners with a shared goal for improved coordination and better health outcomes at the human-animal environmental interface. So typically this looks like a network of ministerial level organizations, often supported by a secretariat and a steering committee, and typically include a minimum of human, animal, and environmental health sectors, but oftentimes are expanded to many other organizations important to a collaborative One Health approach for grand challenge issues. So we like to think of these One Health mechanisms or platforms as truly a strategic way of creating a root system in which we can grow and flourish a One Health approach in countries. And so it provides that structural basis at government level, either national or subnational, that allows for collaboration to occur regularly. As you can see here, this slide highlights that there are many countries in the continent of Africa that have already approached building these collaborative platforms or mechanisms. And they've all engaged very different political will or policy structures in order to see these mechanisms actualized. So the tool that we're talking about today is a 10-step process to support countries to either develop an entirely new mechanism or strengthen an existing mechanism. This 10-step approach is typically operationalized over a 3-day in-person workshop. And this is supported by a 1-day pre-mission that allows really key focal points from the different ministries to plan the use of the tool in a way that meets the national context. So the MCM is applicable to countries in all situations. So we see countries without a One Health mechanism using this tool. We see countries who might want to expand an existing disease-specific task force. And then we typically see countries that already have a fully functioning mechanism, but say, maybe there's a way to evaluate this and improve it. So the primary workshop objectives are first and foremost to develop that One Health mechanism or to strengthen it. The second is what we want to hear from each of the sectors. What do they need to achieve from a mechanism and how can this process support them? And then the third is to have all of the sectors jointly contribute and walk away with an action plan that addresses 18 strategic technical elements. So I'll very rapidly walk you through these elements. So there are 6 core elements. This is often organized for countries that don't have any existing mechanism and need the foundational approach. So we have membership, we have leadership and governance, we have policies and legal frameworks, resources and funding, zoonotic disease prioritization, and activities. We then have organizational elements that help them think through how they are structuring their activities, how are they communicating about it at multiple levels of government and monitoring and evaluation. We have some mapping elements to fully understand the zoonotic disease and One Health activities in countries. And then we have planning elements, and these are actually based on the 7 strategic technical chapters that are outlined in the Tripartite Zoonosis Guide. So your outputs from this workshop, you're going to have a defined role and mission, or an updated one for your mechanism, an action plan based on those strategic technical elements, a final report for communicating with stakeholders, very detailed next steps on who and how you are going to operationalize this plan. And then we typically have a 6-month post-workshop evaluation. So there is a workbook and worksheets to support you with the use of this tool. We are currently in the piloting phase and just finished our first pilot in Kazakhstan and are looking forward to others in the future. And we invite you to learn a lot more today. So here are links to our websites and feel free to reach out if you have any questions. We want to thank you all for your attention and we hope you can use this tool.
No, thank you, Stephanie and Kelly for sticking to time. And I would enjoy other speakers to please, a pace has been set. So let's follow that same pace. So I describe Stephanie and Kelly as pace setters. So we have heard the history around this particular multi-sectoral One Health coordination mechanism operational tool. We have also heard about the capacity building, and much more importantly, we've seen that some of our member states are beginning to align, to this particular tool. So on that note, let me invite the second speaker. So the way I want to run this is that let's first of all take all the presentations, since they are all interrelated, then we can now take the questions after that. So let me invite the second speaker, who will be taking us through the Joint Risk Assessment Operational Tool and lessons learned on its operationalization. And this is Dr. Sophie, who is a Global Surveillance Coordinator, Food and Agriculture Organization of the United Nations. So Sophie, the mic is yours.
Thank you so much, Dr. Tesh, for the nice introduction, and many thanks also to the organizers for inviting me to speak at this very important One Health conference. And I'm just really a voice of all the many people in the different organizations and worldwide and also in Africa who contributed to the success and are still contributing to the success of this joint risk assessment operational tool that I will introduce to you today. So this is the structure of the presentation. I'll show you the key principles for joint risk assessment and introduce the tool to you and the 10-step JRA method, and then talk a little bit about the operationalization as well. So why do we need a joint risk assessment? Well, we came to realize that different sectors will estimate risks of the same hazard differently. So during a meeting in Asia that we conducted in 2014 between FAO, WHO, and OIE, we invited animal health and human health sectors, and we asked each of the groups to assess the risks related to H7N9 avian influenza, which actually had emerged the year before in China. And you can see the results of these risk assessments in the graph here below. And are you surprised about the different risk estimates that came out? Well, we were not entirely surprised, because it just proves the point that zoonotic diseases do need a different approach, a One Health approach to risk assessment. So all relevant sectors and stakeholders are required at the table to bring their expertise and data, and that provides the right setting to fully understand the risk posed by the hazards at the animal-human environment interface. And by discussing these different risks and sharing the data, we also minimize the unintended impacts that a decision taken by just one sector in isolation could have on the other sectors or stakeholders. So now I take you through the operational tool. The tripartite, which, as you heard, is FAO, OIE, and WHO, developed the joint risk assessment from what was already available and out there as risk assessment approaches from the animal health or the human health sector, and available from the different organizations. And JRA was created as a routine structure and approach for conducting risk assessment, both at national but also at subnational levels. And it helps identifying priority hazards at country level. By involving all the relevant sectors in the technical risk assessment, we really put a One Health approach into action. And obviously, by bringing these sectors together regularly, we foster regular communication by conducting joint risk assessments. The outcomes of such a risk assessment allow decision makers to implement evidence-based approaches for risk management and also communication. And by going through the data available, we also realize all the data and the information that is missing. And we have a clear idea on knowledge gaps that need to be filled, which can be attempted before the next iteration of such a risk assessment. So the joint risk assessment operational tool allows the technical staff to conduct this risk assessment in a qualitative way. We've chosen a qualitative approach because that allows us to conduct such a risk assessment even in emergency situations or on emerging new threats where data availability is scarce and